kudos for a fantastic job as usual. And please go ahead, Srini, and take over.
Thank you, Ravi. Happy Father's Day to all the fathers out there who work hard every day to help the families and working as a physicians. So thank you. And thank you, Ravi, for giving me this opportunity to be serving as a CME chair, putting a trust in me. As Ravi said, we have a great CME team headed by Brahm Sharma, doing a ex-team speakers coming in from all over the world. I think give the talk. So please join us in the convention in Philadelphia. So I think with over the last 1 year, we have over like 10 CMEs, each one of them attended by like over close to 200 people in many of the webinars. So I'm happy that we could have so much interest from all the members. So I think we have a really excellent talk by Dr. Nirvetla Garu today. As you all know, I think Dr. Nirvetla has been spearheading this salt problems all over the United States, starting one city at a time from Springfield, Ohio. So he's going to let us know today about different aspects of the salt. And before, I think as Sunil Kaza was supposed to join, but for some unclear reasons, he's not able to join the webinar today as a moderator. So I'm just going to introduce Dr. Naravetla Garu. So Dr. Nirvetla is a esteemed cardiothoracic surgeon working in Springfield, Ohio, with a mission to prevent the heart disease, the #1 killer worldwide. So he's received his medical degree from Usmania Medical College in Hyderabad and followed by general surgical training at Jewish Hospital and Medical Center in Brooklyn, New York. He was trained in cardiothoracic surgery in I think Cincinnati, University of Cincinnati, Ohio, and he's been doing a practice in Springfield, Ohio. Did over 10,000 cardiovascular procedures in his lifetime. So his Consumer Research Council has placed him on the list of America's top surgeons for over 10 years in a row. That's a great achievement. The president of Springfield Chapter of Commerce in recent article called him one of the most successful people in his field. Presently is focused on raising awareness of dangers of table salt. He has written 2 books on this subject alone and another chapter in a textbook, which have received much praise. In addition, he writes a blog at saltkills.com. So without further ado, Dr. Naravetla, please take over and educate us about the salt and the problems with the salt.
Srini, thank you very much. I hope you can hear me all right. Can you please say something? Yeah.
Yes.
You can see me all right as well?
Yep.
Okay. Thank you very much. Thank you, Ravi, for giving me the opportunity, and thank you, Srini. And I hope Sunil will join at some point. And I'd like to engage him in a conversation as well. And anybody else in the audience who are already signed in, I'd like to have a conversation with him as well. So today's talk is about what we see as a cardiac surgeon. Not many cardiac surgeons have taken the time to talk to the rest of the membership because we're way too busy and too tired, to be honest. But I stumbled on this problem of heart disease among Indians about 15 years ago due to a family event, to be honest. But anyway, I kind of stumbled on the reality that one of the most important preventable problems of heart disease among Indians is actually hypertension, which has not received much attention as much as, let's say, smoking or statins. So I researched this subject quite extensively. My family joined in this effort. And we as a family have taken up no salt diet for about 15 years now. And we try to promote this idea of prevention of salt use in our culinary, at least that long, written in books as Srini has mentioned. So I want to share with you what we see at the ground level from the trenches, so to speak, that I would like to share with you and motivate you to participate in prevention. We have to look at heart disease as a preventable disease as advocated by American Heart Association, which says 80% of the heart disease actually is preventable. And I'm going to put that number even higher, to be honest. So maybe not so much in the underdeveloped countries, But in the developed countries, vast majority of the heart disease is preventable. So let's work on that. And heart disease affects Indian physicians. And among the 10,000 plus operations I've done, as Srini mentioned, I've operated on dozens of Indian physicians. I'm saying dozens of Indian physicians and non-physicians. So there's a lot of information that is not percolated up from what we see in surgery. And I like to use that as a platform to motivate you to participate in prevention. So let's get started. So thank you all for those who have participated in this talk. Anytime I see somebody eating healthy, I give them a 3x5 card that looks like this. Let's say if somebody's walking by me drinking water, I stop him, giving this a gold star. Thank you for engaging in prevention. And on the back, you have all the things that table salt does. So thank you all of those who have taken the time today on a Saturday morning on Father's Day to listen to my spiel, so to speak. And what happened here? And those who don't want to participate. So many naysayers sitting on the sidelines are totally opposed to it. Just tell them, don't do it yourself. Don't do it yourself. And don't keep mopping the floor when there's water on the floor without turning the faucet on. That's where the source of the problem is. All our procedures and pills and everything that we do as physicians really actually is mopping the floors without turning the faucet on. And this is where the prevention is. This is where our treatments are. Our treatments are not curing anything. Our treatments are controlling things. Or even a big operation like heart surgery that I do every day is not actually curing the disease. It's controlling it. Just like you take a pill for high blood pressure, it gives you longer term relief perhaps, but still is not cure. So treatment is not equal to cure. And better still is prevention. I hope this illustration from my book Salt Kills makes that point. So let's start with a patient with that we did just recently, and we do this kind of patients many times. Picture of an aortic valve, bicuspid aortic valve. So aortic valve, as you know, is supposed to have 3 cusps, but instead this one has only 2 cusps, congenital bicuspid aortic valve. One of the first things that struck me, this has been right under my nose all these years. I've been a heart surgeon for 40 years, and first 25 years I didn't pay attention to this because I was too busy, building my practice and making a living, taking care of family, etc. But I did not focus on prevention as much as I should have done until this light bulb went off 15 years ago. So classic example of a bicuspid aortic valve. This other example, this is not a congenital bicuspid, but these are 3 cusps, 2 of them fused, did not separate at birth. Another variety of bicuspid aortic valve. And what do we see when we cut it out? This is what we took out. Chunks of calcium and cholesterol like rock, cement, rocks that are obstructing, the valve is not opening and closing. So anybody in the audience who's a cardiologist, internist, whoever, do you think this man has a calcium or a cholesterol problem? No. Why don't we put a bicuspid aortic valves and statins? Why don't you tell them don't eat calcium? We don't, because that's not the problem. The problem is turbulence. So when somebody has a aortic valve bicuspid, often they have a heart murmur. They have a heart murmur. So if a pediatrician detects a heart murmur, they should be getting an echocardiogram to see how the valves are working. Heart murmur indicates there is a turbulence inside of the heart. When you put a stethoscope on somebody's chest, you're supposed to hear only the closing and opening of the valves, loved up sounds. But if you hear a murmur, which means there is turbulence. When the aortic valve is bicuspid like this, if you can imagine, the blood flow is coming through this hole, which is not in the center. Supposed to be here. The blood flow is supposed to be coming right in the middle. So the blood flow is not going straight down the path as it's supposed to go like this. Laminar flow is the name that is used for this. So turbulence means this. And the turbulent flow, the blood flow is going in different directions and that causes injury to the valve tissue. An injured valve tissue is a prime location for subsequent buildup of cholesterol and calcium. It's not because this person or any number of bicuspid valves have cholesterol or calcium problem. They might have that too in addition, but it's because there is turbulence in the path of the blood flow. That's what caused the aortic valve disease. And most of these people, even though they were born with this bicuspid congenitally, born with it, but it has taken 30, 40, 50, 60 years for them to come to surgery. Majority of them come to surgery in the 50s and 60s, sometimes even a lot later than that. Hello, Sunil. Good morning. I heard good to see you log in.
Technical troubles.
That's okay. You just joined in. I was showing a picture of aortic valve, bicuspid aortic valve. What happens in a bicuspid aortic valve? And what does a heart murmur mean? This is laminar flow when you only see closure and opening of the valves. But when there's turbulence, you hear heart murmur. And that predisposes the valve tissue to development of calcium and cholesterol. And that's why we excise the valve. Real quick, I want to share with you a video if I can get it to play. So what I like to share with you on this video is the coordinated movements of the parts of the heart. When the heart pumps, the aorta relaxes to receive the blood. When the heart pumps, the artery relaxes. Heart pumps, artery relaxes. Every single time, 24/7, nonstop. There's a coordinated action going on between chambers of the heart and the valves. More importantly, the blood circulation consisting of the aorta and great vessels and all over the body, all the way down to your radial arteries and down through. That's how you feel the pulse. The arteries relax and contract, relax and contract in coordination with the heart function. The second thing to note is in these coronary arteries all over the body, they bifurcate and trifurcate and branch and branch and branch all over the place. So let's keep this information in the background and go back to my slide presentation. Why that is important? This turbulence. Why is this turbulence happening? So as you saw in the previous picture, every time the heart pumps, the artery is supposed to relax. So why we are not afraid of high blood pressure is because we need to understand high blood pressure at the ground level. What is high blood pressure? I go around asking doctors, nurses, medical students, and people around, what is high blood pressure? And they all stumble on an answer. They say, that's something we take a pill for, this and that. But we need to have a good basic understanding of what exactly is high blood pressure, why we should worry about it. So I will try my best to explain that. And here is a picture of dances with stars, man and woman dancing. It's like the heart muscle pumping and the arteries relaxing. That means each time the heart pumps, the artery relaxes. Each time one dancer moves one way, the partner moves the opposite direction and goes in a coordination fashion, back and forth, back and forth, back and forth. So, but once you have high blood pressure, what it means is the heart is pumping, but the artery is not relaxing enough. The heart pumps, but the artery says, I can't relax enough. That is high blood pressure. Loss of adequate relaxation capacity, normal relaxation capacity. That means the wall of the artery is offering resistance to the blood flow and the pumping function of the heart. So they're no longer in a dances with stars, coordinated dancing movement. Instead, they are in this corner, they're in a boxing ring. Every time heart pumps the blood, so the heart is not relaxing, and certain portion of the bloodstream are offering more resistance than others, and we'll get to that. So we are, by our own actions, high blood pressure is totally do-it-yourself thing, with rare exceptions. So we jump from a Dance with the Stars platform onto a boxing ring. That's what we did. So every time you look at high blood pressure as a situation, oh my God, my arteries don't relax the way it's supposed to be. If you look at it that way, you know suddenly a scary things happen. You started a battle inside of your body between the heart function and the arteries. You started a battle, a war, if you will, in which there is no winners. In this war, everybody's a loser. The heart is going to lose pumping blood harder and harder to get through. And the arteries are going to lose by fighting this blood flow instead of relaxing enough. If you understand at that level, you'll suddenly get scared about high blood pressure. It's not a simple thing I just can lackadaisical about it. So high blood pressure affects more than 1 billion people in the world. You all know that. And more than 100 million, 300 million actually, Indians have high blood pressure. A vast majority of Black Americans have high blood pressure. Even in the most advanced countries, the control of blood pressure is only about 50%. In India, it is in single digits, actually. Diagnosis, treatment, and control in many parts of India, according to ICMR, is in single digits. Is a catastrophic problem. Is a problem number one. We all need to understand at this ground level and act on it and engage with all the agencies who are trying very hard to control high blood pressure and do this. I'll go further and see what all this battle has done to our body. Okay, so let's go on. So this is an example of a blockage in the carotid artery. You see this one? So this is a carotid artery angiogram. The blood flow goes to the common carotid artery and hits this fork, this bifurcation, point of maximum turbulence. Cholesterol blockage almost always happens at the takeoff of the internal carotid artery. Almost always. There are exceptions, but by and large. So external carotid artery, internal carotid artery. Why did the blockage happen there? A question that I didn't ask myself. So I don't blame anybody for doing that. And I certainly started asking this question 15 years ago and want to engage all of you in asking that question. Why did the blockage happen only here, not anywhere else? So what is going on here that is so special that the blockage happened here? That's a question we need to ask. And this is what came out of the blockage, hard rock from the blockage. So this is a very interesting anatomy. So there's anatomy and there's surgical anatomy. Now, surgeons have a different perspective of anatomy. That's why I'm happy that you give an opportunity to explain from the surgeon's perspective. So this is again the carotid artery. Please bear with me for a moment. It's going up the neck. It's bifurcating here. This is an internal carotid artery going up, external carotid artery. Okay. So a trick question people ask, name to me the branches of the internal carotid artery in the neck. A trick question. Name the branches of the internal carotid artery in the neck. The answer is none. Okay. Internal carotid artery does not have any branches in the neck. Whereas external carotid artery has multiple branches right from the takeoff, right as it starts. Please indulge me for a moment on this anatomy. So as the artery forks into two, the external carotid artery is anchored, rooted, immobilized, stuck, whatever you want to call it, into the tissues of the neck and the head, right here. Whereas the internal carotid artery has no branches. As a result, as the blood hits this fork, this part is immobilized, this part is free. So this part is doing bobbleheading, constantly doing this bobblehead. It's almost like you have a seat belt across like this, where this is all immobilized, but this one is hanging free. So your head is going, constantly doing this. point of maximum turbulence. Point of maximum turbulence is why you get this blockage. If it's a cholesterol problem, it should be all over, right? But why here? There's something happening right here. Why the cholesterol builds here? So there's a story behind every single location in the body where there is a blockage. There's a story behind, a local story of turbulence, local story of bifurcation, local story of combination of immobilized artery versus not immobilized artery is where the blockage builds. And that is the turbulence. And I'll show you other examples. This is an example of a cardiac cath angiogram of the heart, those who are non-cardiologists. So there's a catheter in the left main coronary artery. There are two right and left main coronary arteries. And the left main coronary artery supplies blood to most of the heart muscle. And this left main coronary artery is blocked right here. So this is often referred to as the widowmaker blockage. Many of these people don't have any symptoms. First thing happens is they are dead. That's it. This is a man who was walking around, nothing, he was playing golf, went to sleep normally, didn't wake up. He was in the golf, fell over and dead. Most of these people are actually young. And this fortunate fellow somehow survived to make it this far. So what happens with this blockage? When this goes down, the heart muscle loses blood supply almost instantly, like you turned off the light. And they have no opportunity even to say hello. Oftentimes they're going to VTAC, and they're dead immediately. So this is a story of left main coronary artery disease. And I have a reason to believe the vast majority of the 14, 50-year-olds in South Asian population who are suddenly dead have some unfortunate distribution of this coronary anatomy like this. And what's happening here? So the blood is going through here, hits this trifurcation. Blood is hitting this tri-junction, point of maximum turbulence. The blood is going this way. The blood already left once the heart pumped the blood. And if you're driving on the road, hit a fork, you'll slow down to take one of these. But this car has no brakes. So what's going to happen? You're going to keep on thrashing on the sidewalks because you cannot control your speed. So it keeps on happening over and over and again, year and year and out, 24/7, every heartbeat. And the inside of the artery is damaged. Inside the artery is damaged and cholesterol builds over there. Very simple. In this picture, do you see cholesterol anywhere else? No. Anywhere else? Not much. Why is it here? That's a local story. And that's this kind of blockage, unfortunately, if it's a different location, for example, cardiologists like Sunil and Srini can go across the blockage and put a balloon and stent, open it up. We as surgeons go around and build a bypass somewhere here and there. So to make up for this blockage. But some of these people don't come to any one of us, our care, they're dead. Even if you do a stress test, often they have this so-called balance ischemia. You don't see an area of diminished blood flow. You could miss this, unfortunately. But this is an unfortunate person whose arteries go through this trifurcation. So here's an illustration. If you're a driving car, hit a fork, you're going to slow down, right? To take one of these sides. If you don't slow down, you're going to hit this corner. You're going to hit this corner. Not just once, but over and over and over again. And as a result, this is all damaged. And cholesterol and calcium will build. Yes, if you take a statin pills, the chances do decrease, especially in secondary prevention. If you already have a stroke and or a heart attack, there is reasonable data, I would say, reasonable with quotation mark, that secondary prevention, statin has a significant role, but doesn't take the role of not stopping smoking or not controlling or preventing high blood pressure. Not even close. There's not enough medicine you can give to somebody smoking unless to make up for smoking. The best thing you can do is quit smoking. And I will tell you right here, right now, that if you don't prevent or control high blood pressure, there's not enough statin you can give to prevent this problem. It will reduce some. In primary prevention, there's more data supporting use of statins in certain circumstances, but doesn't take the place of preventing the top two things, hypertension and smoking. We got to do this. So here is the example of our fellow that we just saw, a trifurcation. And here's a car hitting the traffic. This guy stopped here to look where I'm going to go. But if the blood has already been released, the bullet has left the gun, and he's going to hit one of these corners. So the constant turbulence going on right here. Left main coronary artery disease in young people especially often has this trifurcation, even four-way, there's sometimes 4 arteries coming off from the same spot. And that's where the maximum cholesterol builds up. So I hope this is amply clear. The other local problems, why local pathology, pathophysiology, hemodynamics are important in creating the pathology. Here is an example of abdominal aortic aneurysm. Why does abdominal aortic aneurysm almost always starts in infrarenal location, below the renal arteries? So this aorta, renal artery, this is the aorta above the renal arteries certainly has multiple branches. So this one is a superior mesenteric artery. Just above that is a celiac artery. And these 2 renal arteries. And then in addition to that, this vena cava, the left renal vein crosses across the aorta, right in this location. So what is happening here? Just like we saw in the carotid artery disease, this part of the aorta is anchored, stabilized, stuck. Whereas the blood, as it goes down right across this point, if you have high blood pressure, suddenly opens up. And if you are into gardening, if you want to your water to spray wide, you're going to narrow the nozzle. If you open the nozzle wide, the pathway is straight. If you narrow the nozzle, it goes sprays. So here is an example. When the blood comes up past this renal vein, it's going to spray. And if you know somebody with aneurysm under surveillance, most important thing to tell them is, of course, not to smoke. Equally important is the growth of the aneurysm is actually proportional to hypertension, not so much to statins or cholesterol. If you control your statins, but you're still smoking and your blood pressure is not under control, this aneurysm will continue to grow. So same, different dynamics here, but there is dynamics. Local dynamics is why the aneurysm becomes like this. So if you don't want to have an aneurysm, that's what you're going to do. Now, we talked about why cholesterol builds in the arteries related to hypertension. This study published March 23. This actually, Sunil sent this to me. You might remember this. From Sweden, Association of Sodium Intake to Coronary and Carotid Artery Atherosclerosis. They studied 10,000 people. Urinary excretion, they did one of the most detailed study, as Sunil pointed out. What they found, very interesting. Salt intake, more salt intake, more cholesterol buildup, whether you have high blood pressure or not. And this is not the only paper that has come recently. There's been a growing number of papers showing that sodium intake, salt intake, I should say, keeps on increasing your cholesterol buildup with or without hypertension. Very, very important point to know. Some of us seem to think, oh, I don't have high blood pressure, so I don't care, I can eat as much salt as I want. No. Just from the atherosclerosis point of view alone, we have to pay attention to salt intake. We do have to pay attention to salt intake. And how does salt cause atherosclerosis? We don't quite know exactly, but there are several different mechanisms proposed in the same journal from the European Journal of Cardiology in March 23 editorial. So there is obviously high blood pressure right in the left corner, causing the damage just from physical injury. But there are other problems. Salt produces, there's more and more evidence to point out that there are multiple different pathways that promote atherosclerosis by adding salt in our diet. And this is from European Journal of Cardiology. You might want to look that up. So what is salt doing, hypertension doing to us? Very simple way to understand. Of course, there are multiple pathways, which, as we just saw, very simple ground level way to understand. Salt is like a sponge, retains water. That's why people in heart failure retain water, we keep giving diuretics, right? So we keep on giving diuretics. That's not the only mechanism, by the way, but easiest way to understand. So I walk around with a sponge sometimes. So think about salt as a sponge retaining water, and more water you have in your system, more volume to deal with, and the pressure goes up. That's one mechanism. So once we develop hypertension for whatever mechanism, you have the scratch pad. We just saw the scratch pad effect on multiple locations of the body. So that's one way to understand. And this is 2004 WHO report published in 2009, actually, that high blood pressure alone is killing more people than tobacco. High blood pressure alone is killing more people than tobacco. So this is around the time we were writing our book on salt. We had many other softer looking titles for this. When this got released, my editor said, well, say it the way like this. It is killing people. Go with salt kills. You'll get attention. So it has gotten attention. It also got some rebuffed for obvious reasons. We understood that. There are some people going to object to that. But we need to make this point. High blood pressure is killing more people than tobacco. This is not my point. I am the carrier of the messenger. When I'm walking around with the salt kills button, I'm a messenger. This is not my message. It is coming from not only WHO, it is coming multiple organizations, CDC, American Heart Association, NIH, Mayo Clinic, Cleveland Clinic, you name it. Literally dozens of organizations trying to draw attention to the problem hypertension. We're still not getting enough attention. Why? Because there are many people like me in the ground level, grassroots level, trying to raise awareness, but being run over by the salt industry. They want to make you believe tobacco salt is okay, or some salt is okay, or some limit is okay, or actually you need some amount of salt, which is incorrect. And sea salt is even better. So sea salt, these are all untrue statements, but they are doing that. Those who are joining on this call will to hopefully join this mission to engage in hypertension reduction. So American Heart Association says, at least 50% of the heart attacks, direct contribution from hypertension. Of the 80% of the heart attacks that could be prevented, at least 50% are coming from that. So we need to look at salt in the same platform as smoking. At least more than that. That's why we came up with this slogan, public enemy number one. Public enemy number one. So this weekend, as I posted in the WhatsApp groups, I was in Chicago pitching the salt reduction campaign to American Heart Association, American Medical Association, AMA, the conference of delegates, House of Delegates. And one of my classmates, Dr. Subbarao Bolapalli, who is very involved in AMA, introduced the resolution from his Connecticut delegation. I spent 3 days trying to do this. So true story. One Indian physician came, sat next to me in the back of the hall, picked up a bag of potato chips and sat next to me and saw my salt kills button. He said, what is that? Well, this is what it is. And we were not able to talk too much because the conference going on. He said, I can't imagine eating without salt. I like salt. I like the taste of salt. And I would not consider eating anything without salt. Emphatic statement. Then I took this card and laid on the table. And I said to flip it over. He flipped over. And all these listed things are on there. And they just looked at silently. He put away that bag of potato chips and put away his soda pop. And said to me, okay, said to me this. I can't imagine I was eating this, all this thing, doing this to myself. This potato chips tastes horrible. Suddenly something he couldn't live without. The moment he realized how many different ways he's hurting himself, suddenly it doesn't taste good anymore. So it doesn't taste good anymore. That is an almost instant change in his thinking. He's a physician. Almost instant. That's the impact of this and this salt kills button, my friends. Some of you, may not, agree with me on me carrying this button all the time, but I don't go anywhere without it. whether I'm attending weddings, traveling, any number of people engage me in this conversation. I'm in the airport, in the hotels, the lobbies, wherever people engage me in this conversation. I had an opportunity to talk about it, engage in prevention. So this doctor's life is changed. This is not an isolated story, but it's the most recent story I will share with you. So this doctor's life is changed like a light bulb. He went reverse direction. Okay. So this is how many different ways this table salt is hurting us. Not all of them are directly from high blood pressure alone. There are other things like autoimmune diseases, type 2 diabetes. And I'd like to go over that in a moment. But these are so many differences happening, and everybody, whether you have high blood pressure already or not, you're having it. It's coming. So see this one, erectile dysfunction. Something I learned from attending one of Amit Chakrabarty's talks. I did not know that high blood pressure is a risk factor for ED. And number of medications that we prescribe for high blood pressure independently are risk factor for ED as well. I'll tell you another instance. One day I was traveling in the airport. 3 college students sitting close to me ordered a pizza, and without even tasting, they're already putting salt on it. I was sitting there. I couldn't stomach it anymore. I'm on a mission. I'm on a crusade. Nothing stops me. Okay. So I said, I have nothing to lose. So I went up to the table and I dropped one of the cards. Okay. Right on there. So you guess what happened? So he said, one of the kids, these are nice kids actually. Wait a minute, sir. I don't have any high blood pressure. Why do you worry about it? Then I said, do you want to wait till it comes? It's coming. If the way you're doing it, it's coming. Do you want to wait till it comes? And the second guy said, well, when it comes, I take a pill like everybody else. What's a big deal? So that is a study attitudes a lot of people have. This is a pill train people get on. And our retirees and the ones who are in nursing homes now on average getting 15 to 20 pills a day. And it all starts most commonly with high blood pressure pill. You put them on a pill train, you start with 1, 2, 3, 4, 5. It just keeps going. So it starts with. So you want to get on this pill train, it's not going to be one pill necessary. It's okay, I'm going to take that pill and I control it. And I said, well, that's your strategy. Then you're going to need another pill. I said, what is that pill? He said, see that TV advertisement that just went by? When the moment is right, you need a pill. I mean, by the time you get the pill, the moment is gone. So you might start stocking up on those pills. You see the advertisement, there are 25 million Americans at least, maybe more, already on Viagra type medications. Do you want one of those? You know what happened? As soon as I said that, they pitched the pizza or something else. They just threw it away. So right then and there, I sat there and wrote the blog. It's called Not Now Honey. If anybody's interested, go to Google and use 3 words. Not Now Honey. Okay? You do that and the relationship between table salt and ED comes up. It motivates young people to start watching before they get into trouble. So these are different things I've been doing. So there's no doubt, you should not entertain any question that table salt is a primary contributor for hypertension, majority of us. This is from father of preventive cardiology, Dr. Stambler, that he's gone through extensive types of research, clinical observation, therapeutic interventions, control, RCTs, animal experimentation, physiology, on and on and on. That's what he said, okay? So you should not entertain. So how much salt is okay is a kind of upper question, but American Heart Association position is often misrepresented. American Heart Association says, for most people, 2,300 milligrams is okay, as Institute of Medicine said, but actually most people need to eat less than 1,500 milligrams. Less than is the operative word. Less than 1,500 milligrams. People interpret often that I need 1,500 milligrams or 2,300. No, you don't. So American Heart Association position is most people require maybe around 500 milligrams. We don't know even that, but you can get that from your daily, whatever food you're eating. Most people do not suffer hyponatremia, with rare exceptions. This is Louis K. Dahl, father of hypertension. In his testimony to Congress in 1969, he stated, no physiological need for table salt or sugar. Anybody has a question, you can Google this name and check out his testimony to Congress in 1969. So that is, and Dr. Dahl, as far as I know, is a guy who has done the most research than anybody else as a single physician on hypertension. And for that contribution, American Heart Association honors him as father of hypertension and as a Louis K. Dahl Memorial Lecture every year to honor his contribution to our understanding of hypertension. So, World Health Organization recently issued this statement: massive effort needed to reduce salt and save millions of lives. Massive effort needed. It's a cry for help. It's a cry for help. So we as physicians need to understand, my hope is that hypertension at the ground level, what exactly are we doing to us? Our arteries no longer relaxing the way they're supposed to. It's a catastrophic development. We are creating a battle inside of us, catastrophic development, as a result of which both heart and the blood vessels are going to lose. So anyway, we are supposed to eat lots of fruits and nuts. Why? Because they all have many reasons, but one of the simple reasons is they all have high potassium, very low sodium. By the way, this sodium is what we need. This is kind of sodium we need, not table salt. But we need a lot more potassium, Same thing with nuts, lot more potassium and very little sodium. And this is how we are supposed to eat, but we don't. But instead, we are eating 70 times, according to one of the professors, of the sodium salt that our kidneys can handle. And at time, and eventually, it gives up. It gives up. So how soon it gives up depends on this study, again done by Dr. Dahl, study on salt sensitivity. If you're in this green line, not salt sensitive, salt resistant, or the red line, salt sensitive, blood pressure shoots up very quickly. Unfortunately, Black Americans are very salt sensitive, closer to the red line. And this is the green line. Least salt sensitive, we call them Dahl R rats, Dr. Dahl S rats. These are commercially, you can produce them now. Indians, by the way, fall somewhat closer to Black Americans. Caucasians, about 25% are salt sensitive. And based on masala study and many other studies, hypertension is much more prevalent in South Indian population, more than 40%. And that is our principal problem. Not to mention that, you must have heard recently that the BMI criteria for South Indian population has decreased. I don't know how many know that. BMI criteria for South Indian population is decreased because we are small people. I would present to you that blood pressure criteria perhaps should also be decreased for Indian population. And on the screen is a study from Yanomami Indians and many other population. My son brought this to my attention, actually. He was on a mission trip in Ecuador, and they were went into jungle areas. And there, the average blood pressure was only 80 or 60 on people who don't eat salt. And now 13 different populations have been studied, including one population, Arunachal Pradesh area. One of the doctors reported this to me. The average blood pressure is actually 90 or 60 or less. Only royalty who have access to salt, their blood pressure is very high. So I will present to you that if we never consume salt, our blood pressure, normal blood pressure, might actually be lower than what present-day American Heart Association actually uses. So 120 over 80 is already, I will present to you, that is at least 25 to 30% or more higher than what we might be. So just for your consideration. So what is the other thing that happen? The heart is pumping blood, the arteries get damaged at bifurcation and forks, and where it's anchored and not anchored, whether you reach a place of that differentiation. Something else happens. The heart is also working hard. The heart is pumping iron, okay? It's pumping iron. So it's getting bigger. The heart is getting enlarged. This is an enlarged heart, thick heart muscle. As a result of pumping against resistance, instead of being an elliptical heart, it becomes round heart baseball. And we call that diastolic heart failure. What is diastolic heart failure? The heart can still pump, but cannot relax. The heart can still pump, but cannot relax. So different degrees of it. This is an illustration from our book. So is swinging at the golf ball, but you think as hard as you swing, that's how the ball goes. It is true to some extent, but also if you cannot take your golf club back as far as you want to, it also limits how far your blood flow will go, and that is diastolic heart failure, loss of your backswing, and different degrees of backswing. So even though you still have a strong forward swing, and actually the systolic function might be even better. I would suggest to you, if somebody comes to you saying my systolic blood function is 70%, normal is only 50, 70%, you would stop and say, why is your heart working harder than it should be? Why? Because it's compensating for the loss of the relaxation. You lost the backswing, so you swing harder. That's the first missed sign of diastolic heart failure. So lastly, in the last few minutes, this is from Sunil from Vanderbilt, how type 2 diabetes is connected to heart disease. So here it is, this Dr. Jan Setsi, who reported from Vanderbilt that he was studying cosmonauts from Russia, then went to Europe, then came to Vanderbilt, finally did his study after 3 decades of study. What he found is the cosmonauts were not drinking enough water. Why? But they're getting all right. How are they doing? And he figured out that they were actually breaking down more glucose than supposed to make up for the water. So this is an interesting equation. This is glucose molecule. This is oxygen. When they, and equals, we know this, carbon dioxide, you inhale oxygen and exhale carbon dioxide. We know this part. But we have not paid attention to it. Also, this equation also produces 6 molecules of water. We didn't think much of it actually until Dr. Setsi pointed out. And what this is important is that he found out through his research that people are breaking down more glucose than necessary to get to this one. Instead of drinking enough water, you keep on eating salt, compensation mechanism, you're breaking down more glucose than necessary to produce more water. And this breakdown mechanism facilitated by producing more steroids than necessary. I actually showed that in human volunteers as well as animal experiments, that people who are eating salt over time start producing more steroids than necessary, precipitating a metabolic syndrome, which is what he said. Okay, and that's how is a connection. And more recently, this study again published from Stockholm, researchers found that each gram of sodium per day was linked to 43% higher risk of type 2 diabetes. So my friends, I raise a challenge all the time among Indians. Do you see anybody with type 2 diabetes who does not have high blood pressure? I ask this question in every single meeting I have. It is very rare, not type 1 diabetes. Among Indian population, I will present to you that hypertension precedes type 2 diabetes for 1 to 2 decades. So if you want to prevent type 2 diabetes and all the things that go with it, you must start with preventing hypertension. You must start, and then of course, heart disease and everything that follows. So I would present to you that if you want to stop type 2 diabetes, we must start with preventing hypertension. You hit 2 stones or many birds with one single stone. We must start with preventing high blood pressure. So you all know that high blood pressure is very high among Indians, 4 times. This is a study from actually Dr. Ines and Ines. So you already know that. So you already know that the hypertension, the silent killer, has been stated for a long time. So you should accept my title, Salt Kills. And this is a title from one of the review articles on Dr. Dow, Salt, Deadliest Spice of All. Salt, deadliest spice of all. I think I'm going to stop there. And I will give some time for any questions. There are many more slides I can share, but I will stop here. And I would invite any discussion and conversation. And thank you for your indulgence. I appreciate the opportunity very much. And I hope you all live a...
Excellent presentation, Dr. Nirvetla garu. As a cardiologist, I think I want to ask you a question about the surgeon's perspective of sudden cardiac death in LAD, proximal LAD lesions when they go into VFib. Is there anything you see when you're doing the surgery in the proximal LAD, apart from the trifurcation, bifurcation, what you talked about, which is different than what we see in other areas?
Yes. Yes and no. There are different levels. I mean, I would say branch levels, different branch levels, starting from the very proximal to very distal. When there is a proximal LAD, not to mention the left main, there's usually a septal branch or a diagonal branch taking off almost at the same place. You may not have, when you go back to some of these proximal LAD lesions, you will see that. And in very close proximity, or at least right there, is a fairly good sized septal branch or a diagonal branch, creating a bifurcation or trifurcation right at that location. And that's what precipitates build up at the proximal LAD. So that is what is different. You don't see an LAD just going smoothly by itself without any branches. Suddenly have a blockage. You see that in diffuse coronary artery disease, which happens in fairly uncontrolled type 1 and type 2 diabetes. We also see it in one other setting, and that is familial hypercholesterolemia. Familial hypercholesterolemia are defined as cholesterol levels over 400. And the youngest person I've operated with that kind of a problem is 18-year-old. So we see cholesterol build up without any of these precipitating factors. But by and large, garden variety, left main and proximal LAD. Excellent question. Thank you, Srini, that always see this branch. It is one of those things. Eyes don't see what the mind doesn't know type thing, okay? And if you look at a microscope on a cancer slide, if you don't know what you're looking for, you don't know what you're seeing. Same thing, if your mind knows what you look for, the eyes will see it. So the same thing, once you kind of process this, what I kind of presented today, you might have a slightly different angle to what you're seeing every day. I'm hoping, but anyway.
So that was an excellent presentation, Dr. Narvetla, and we have had many discussions in the past at personal level and all that. I agree with most of your points about excessive salt that causes hypertension and all that. So there are some questions from the audience
Yes,
that
sir.
I would like to read out and get your opinion on that.
Okay.
One is Dr. Smita Arakapudi. She is asking about sleep apnea, relationship of sleep apnea in the development of hypertension and rhythm problems, and vegan and vegetarian diet value or proposition for prevention. So I guess the diet is it can take a half an hour talk on diet part, vegan and vegetarian, but at least sleep apnea and hypertension.
Yes, thank you very much. I think both are excellent questions. I am always concerned. India, for example, majority are vegetarians actually, right? Why still so much heart disease? Because, and I read these vegan magazines, they focus on not having animal products. I mean, there is a lot of research to support that. But unfortunately, this veganism is actually a fad, it seems like, and they don't watch salt intake. And I was yesterday in a Juneteenth event, and there's a big tent vegan. They're selling soda pops and potato chips, high salty foods all the time. If you eat a vegan burger, if you're interested in burger, I would say go and eat a real burger anyway, because vegan burger is very salty. So that is where the problem is with regards to veganism. True veganism also must include salt reduction. If not, you're wasting your time. Going back to sleep apnea, great question. I'm sorry I didn't get into that. Sleep apnea, actually, I myself wear CPAP, although I'm not overweight or anything. My son, one of my sons, when he came on holidays, saw me snoring and wake up in the middle, said, "Do you have a sleep apnea problem?" So I went through a formal sleep study, and I'm not as diligent as I should be, but I do wear a sleep apnea. So sleep apnea does produce significant heart problems and lung problems, pulmonary hypertension, right heart failure, possibly left heart failure. There is a lot more to learn about that. I would encourage anybody who snores or doesn't snore in the 50s, overweight. I mean, there are many criteria. Even in random, get a sleep study. You don't lose much. And if you have sleep apnea documented on that, it took me about 3 months to get used to sleep apnea machine, to be honest. Prevention is better than anything. taking pills is should be the last resort. Even if I have to wear that ugly looking thing on my face, on my night. And what I found out once I started wearing sleeper machines during the daytime, I was a lot more alert and awake and I have more energy. I didn't realize during the day I was having these sleeping episodes because I was not going into this REM sleep at night because of sleep apnea. Thank you very much for asking this question, and pay attention to sleep apnea.
To add to that, I think she was asking about the mechanism. I think it is to do with negative intrathoracic pressure causing the pulmonary stretch changes, in turn causing chemo and baroreceptor changes, and it has effects on sympathetic system and renin-aldosterone system, which in turn causes the hypertension. I think that's the mechanism which has been explained in the past with regard to sleep apnea and hypertension. So,
yeah, excellent. Thank you. I agree with you.
Yeah, and next question is, what is the worst offender? The grains grass family, no grain, no pain.
So my own, Mahatma Gandhi addressed this a long time ago. So processed grains, white flour, white as in sugar, white as in salt, white as in processed grain. All three are three greatest enemies from a health point of view. Three great whites. Whole grains, there's some quarters having concerns about that. But whole grain, based on my best available understanding, or should be part of your regular diet. So what I personally do, I eat very little grain, to be honest. And I eat a lot of nuts and fruits. That's my, as I was giving the presentation, I'm eating, oranges. And right behind me in my closet is all this. See this? This is my snacks. I eat nuts of different kinds. So I'm not telling anything that I don't do, okay? So I'm 71, going on 72. I fortunately don't have high blood pressure, not on any medications at the moment. So prevention is very important. Very hard to see a 70-plus-year-old Indian guy not on any medication. I'm sure there are, but not very common. So whole grain, nuts are whole grain. Okay, thank you.
That's good. The plant-based diet and non-processed foods are what most of us recommend and agree. And that's what the lifestyle medicine one of the 6 pillars of lifestyle medicine also is suggesting. And one of the audience members wanted that card image for everyone to look at, the card that you showed.
So I made these 3-by cards. Actually, on one side, I walk around and see somebody's eating healthy, drinking water. I give this card, 3-by-5 card. I can post this JPEG or whatever you call that on WhatsApp group. You can copy and make your own prints. And on the other side is all the things that Salt does. And if I see some stubborn doctors and nurses who just go around eating things, I give them this same card, but it has this on the front. I hope you can see.
Another member asked about the literature supporting your statements, and I would refer them to www.saltkills.com. Is that correct?
Yes, we can do that. Or they can private message me, and I will try to. So I want to reinforce wherever it was sort of my opinion, I've made it very clear. But much of all my presentation is based on American Heart Association positions, CDC positions, World Health Organization positions, etc., etc. So I'm trying to explain it in a simple language and with illustrations what they're saying.
Dr. Sanjay Mutrej, he is asking about association of alcohol with hypertension.
Alcohol is associated with hypertension. And what part of hypertension we're facing now? 1 billion people with hypertension, 300 million Indians hypertension. Their problem is alcoholism, I don't know. So on the flip side, whether a small amount of alcohol is actually beneficiary, there's a back and forth literature on that. Some saying that there's no such thing as safe level of alcohol, and some saying that maybe up to one unit of alcohol with beer or wine may actually be beneficial. There's what is called a French paradox, where they don't have as much heart disease. but what they find is the time they take to do their dinner. See, most of us eat our dinner in 5 minutes or less, but the French take 3 hours to do it. Okay, so, and alcohol is a part of the unwinding process from the day, whether it's the unwinding process or is the alcohol doing it. Which one it is, we don't know. But definitely I would be cautious about drinking more than 1 unit of alcohol. Definitely would be more than that.
Yes, alcohol apparently, binge drinking does cause hypertension, and excessive alcohol use obviously causes the hypertension, and it also affects, I guess, the endothelial functioning, and the endothelial dysfunction causes reduced nitric oxide, and that also can be a possible mechanism in alcohol-induced hypertension.
Excellent, thank you. See, I always learn something.
And salt. There is a comment by Dr. Prabhakar Sharma.
Okay.
Comment on mechanistic matters. Yes, salt plays an undisputable role in the genesis of hypertension and heart failure. However, the kidney has an immense ability to excrete the excess salt and water. So an intrinsic renal functional defect is involved in the pathogenesis of both conditions, namely pressure, natriuresis, and natriuretic peptide receptors resistance. Yes, this is an excellent point that
Yes.
we discuss about, that we have that innate mechanism of kidney taking care of excess salt in many people. Can you, what is your opinion?
So I have this illustration from my book that was explaining the salt sensitivity illustration. So at some point, the kidney does, of course, no questions, kidney is in charge of filtering all the bad things we do to ourselves. But at what point and when the kidney gives up, we don't know. It's not very easy to find out until it's already happened, unfortunately. So by default, from the point of view, by the time you develop hypertension, you've already went beyond the ability of the kidney to control that. So yes, kidney, something has changed in kidney. So Dr. Dahl's focus actually was on the kidney. So he did a lot of experiments on the kidney. In fact, he's the first one to introduce ganglion blocker treatment. He said somewhere the nerves are involved. So in fact, he denervated the kidney to show that denervating the kidney is going to reduce high blood pressure. So intrinsic kidneys failure to control this has happened by the time you develop high blood pressure. But we shouldn't wait till it happens. We don't know when that's going to happen. And as I pointed out, in addition to hypertension, there's many other things that salt is doing. Salt is not benign. So, and I would like him to take note of that. It's not just hypertension. And kidney, based on the Sweden paper just pointed out, damage to the artery is happening. One of the papers that was published from Delaware, if you give salty meal to young volunteers, within 30 minutes, the blood flow in the brachial artery goes down by 25%. So there's something happening immediately in some people. So kidney will try to compensate, but we don't want to challenge that kidney all the time and not knowing what its limits are. So we need to stop thinking that kidney will take care of it. I will eat whatever I want. Or saying, I don't have high blood pressure, I'll wait till it comes. No, it's already, that means you're decompensated. We shouldn't wait for that point.
So there is another question, Dr. Ruchi Wanchu. Many cardiac surgeons, cardiologists, different physicians dying from myocardial infarction and have high blood pressure. Do you think they are not aware of salt intake? Is there more to only salt intake like stress, genetic, lifestyle, etc.?
Excellent question. We all live in a stressful environment. We're not the only ones living in stressful environment. Of course, stress increases the blood pressure. But having, so one interesting study published in Atlanta, this is in teenagers who are playing video games, okay? These are teenagers playing video games. So the half of them were given a defective video game, and the other half were given the regular video game. And the ones who stumbled on this defective video game, struggling to go through the next step, got very angry, upset, all their blood pressures went up, okay? And then they checked them further, urine intake, urine sodium excretion, etc. They were retaining sodium and causing high blood pressure. So stress definitely causes high blood pressure, continued persistent stress. That's why meditation, lifestyle modification, should be an important pillar we all need to know how to manage our stress, starting with before the stress comes. Like, for example, anesthesiologists nowadays want to give pain medication before you cut the incision. We should do the same thing. I do the same. I go have a timeout in the morning before you go to work. We need to have a stress release mechanism, starting before the stress hits you. So stress doesn't preclude. There are different pillars. One doesn't preclude the other one. Okay, so we need to manage this and that's as well. I hope that answers the question.
Yes. All 6 pillars of the lifestyle modifications are important, and
Yes.
and nutrition is one of it. Within the nutrition, the salt is one part of the whole nutrition pillar, and
Yes.
Generally the accepted salt intake is about 23 to 2400 milligrams of sodium per day was recommended by AMA and accepted by most of the organizations, which means it's total of 5 grams of actual salt, right? And we do get the salt out of the foods that we eat, the natural foods.
80% of the excess salt we're getting is from the foods that already have salt contained. And the key word in that 2300 milligrams is stay below.
Yeah.
Not you need 2300.
And again, there are some people who sweat a lot, who are running, 10 miles, 15 miles. They probably need a little bit more salt, and we can make probably exceptions there.
Yeah, definitely exceptions. In fact, there was a nephrologist, salt-losing enteropathies, salt-losing nephropathies, many different conditions. But we're talking about general population. So.
Yeah, maximum many people. But in general, like if somebody comes to the hospital very sick, what do we give? We give salt water through the
yes,
IV.
We do. And we also give 50% glucose. They become hyperglycemia. Yeah. So we have to give those things as needed. But
Dr. Alka Patel made a small comment. Gandhi walked miles to get salt. Now we have to walk back on that path.
No, that is yes and no. The Gandhi salt satyagraha was an important turning point in independence of India, but he never promoted salt. In fact, he is the one quoted as I cannot use this we need to fear 3 great whites, he said, apparently, referring to everybody thought it was Taisildar and Munsif and that. No, he was referring to salt, sugar, and white flour. He advocated against all 3 of us.
So
in fact, I went to
asked,
sorry, go ahead.
About please. What was the slide on kitchen scrubber imply? I guess you are talking about the imbibing capacity of the scrubber. If you put the salt in there, salt imbibes water and retains water.
Retains
water. That's
water.
What you meant, right?
Yeah, yes, I did. And also the scratch pad means once you retain water, your arteries are getting scratched inside. So you're overrunning the ability of the arteries to relax. So there's a friction. There's a friction.
He also asked about ciprofloxacin causing aneurysms.
That's new to me. I will have to look that up. I've not heard that.
I have not heard that.
There may be something to it.
Yeah, that I think there was some data on the tendon rupture and things like that. Maybe something to do with the connective tissue. I don't know exactly how it does. I have not read about ciprofloxacin causing the aneurysms.
I'm not, but it's an interesting point. I will look that up. So this is a learning process. That's why we want to have a conversation. So you need to change your opinions based on evidence.
So yeah, it was an excellent presentation and everybody enjoyed it. And many people have commented that it was an excellent presentation in very simple words. And as a cardiac surgeon, you are at the other end of the treatment thing, and you have taken this as a big cause and fighting for the prevention. That's really commendable, to prevent the disease rather than taking care of doing the bypass and being happy with doing your surgeries. So that was great. Thank you.
Thank you for those kind remarks. Thank you very much. That is...
Dr. Naravatla, I think that was an excellent presentation, great discussion and moderation by Sunil. I have one more question before we, give it to Ravi Kohli.
Yes.
Is there a difference between salt intake and the systolic versus diastolic blood pressure elevation?
I'm not sure. This may be a question for a nephrologist, but I generally say, maybe I'm not entirely correct on this. When somebody walks around with systolic hypertension only, it is related to your activity, anger, etc., etc. But if your diastolic pressure is high, I would take that seriously. That means you have real high blood pressure. If somebody walks in with 140 over 100, let's say, 140 over 90, So your systolic blood pressure might fluctuate with day-to-day activities and your emotional level, but if your diastolic pressure is high, persistent resistance to heart function, that's the way I look at it. Persistent resistance to the wall of the arterial system against pumping function of the heart. So persistent damage is taking place. So diastolic blood pressure must be, the way I see it at the ground level, from the perspective of the dynamics, we need to pay attention to the diastolic dysfunction. Whether salt causes this, I do not know the answer. That's my general advice. Good question, though. Srini, you still there?
I think he's driving.
Thank you, Dr. Narvetla. Ravi, why don't you talk about the presentation? I'm going to just end it with like how they get the CMEs after you talk for a minute.
All right, thank you so much, Dr. Narvetla, and thank you everybody for being here on a Sunday morning, Father's Day, a day, taking a little bit time from your family. Actually, my son came, visited me, and he was making me moong dal pancake yesterday, pesera too, and it was a little bit excessively salty, I mentioned to him, because my salt intake has gone down tremendously over the last few years due to my interactions with you.
Thank you.
Lata doesn't put too much salt in our food anymore. Plus, she lost taste for salt during the COVID infection, so she don't know what she's putting, but she puts as little salt as possible. But besides that, then he made kind of a scrambled egg this morning without salt, and I appreciated that.
Wonderful.
And,
thank you very much for the feedback.
And thank you. And again, I want to thank everybody for joining. And it's like taking salt excessively is like a deficit spending. Just because we have the ability to print and spend like our treasury does, it doesn't mean it's the right thing to do. So I think cutting back on salt is a really must for all of us. I mean, the another thing I'm continue to be surprised that as physicians, we know the physiology, the pathology, and all the all the pathology that affects us. But we have this intrinsic feeling that we're not vulnerable, we are invincible. We never take care of ourselves. We preach to all the patients, but never really practice it. I think more and more, I think we need to be wise and practice what we preach. I remember the doctor smoking before a lot and telling the patient not to smoke. I think that has stopped now, but similarly, I think we need to work on our nutrition and diet and exercise and stress reduction and all those good lifestyle medicine practices. Thank you for again reiterating and keeping it very simple, very understandable, very impactful for all our audience to really take the message home and also preach it to their patients. I think if they practice, they will be able to convince other people. Anyway, and besides commending you for what you have done today, I also want to invite all of you, all the members who haven't signed up for a convention. Dr. Narvetla will be there and he will be giving out those cards for free. All of you come there, right, Dr. Narvetla?
Yes, certainly. I've already.
So come and pick up your cards there. And please sign up for day packages. We have daily packages, Saturday package, Friday package, Friday, Saturday package. And also we have saved some rooms for latecomers. We have a link in the website, rpusa.org and rpconvention.org to book your rooms directly through us. And we have saved some discounted room rates because rooms are sold out because of another big convention happening in the area. So please come to our convention, July 6th to 9th at Marriott downtown Philadelphia. We have an excellent CME program. Dr. Narvetla is also in our CME panel there. Hopefully you'll be able to come on Thursday and present the information that there too. And so please join. And I want to present the plaque now, or do you want, let me present the plaque to Dr. Narvetla for his excellent, I'm sorry. Let me present the plaque here for 1 second. And I really appreciate all of you being here with us. And all right.
The website address somebody asked, www.saltkills.com.
Yes, that's correct. So I write a blog As and when I can explain something. Okay, there's a lot of information out there which is already there. If I can find an angle in simple words with illustration to explain it, then I write about it. That's really what I've been doing for the last 15 years. As Ravi pointed out aptly, thank you for noticing that. We try very hard to keep it simple. Right. My editor says it has to be a 6th grade language. So I work very hard on and off the field to keep it conversation like that. Thank you very much.
Again, besides all the public education, public health, and community service Dr. Surinder Reddy Narvetla does, we want to recognize him for his dynamic presentation today, for his outstanding contribution to the field of cardiothoracic surgery and hypertension and salt reduction. Please, we welcome you as a member of our API Distinguished Speakers Club, signed by our chair, CME committee, Dr. Srini Gangasani and myself. Thank you for your services to API as well as the entire population of USA and the world. Thank you again, and please take over, Srini, for any closing remarks.
Thank you, Ravi. Thank you very much.
One
That's very
comment
kind of you.
on the plaque. We need to change it. We by mistake, I think it came as her for her outstanding contribution. We need to change it.
I think these days her, his, I think they're being interchanged, but we'll make sure.
I wasn't reading. Thank you.
Thank you.
I think
Sunil
it's
pays attention to the details.
Soumya.
Sunil has a knack to find all the problems, and thank you. Thank you again. And again,
thank you, Ravi. Yeah. Thank you, Ravi. I think a happy Father's Day to all again. I think it's been a great privilege and I think an honor to be a CME chair this year. My heartfelt gratitude for this wonderful year we had together. I want to thank my CME committee co-chairs Krishan Kumar, Dr. Sundar Rao, Dr. Brahma Sharma, and members Dr. Gupta, Lina Gupta, Dr. Sharma Prabhakar, and Pankaj Viz, helping me throughout the year for the whole webinar series. If you haven't gotten the certificate, if you registered and attended, please contact Sam at sam@emedevents.com. And I also sent a phone number on the last email with the CME. So if you also shoot me an email, I can help you, or Ravi can help us to get the certificate if you haven't gotten the certificate. Again, thank you. Have a great, wonderful year, and see you all in Philadelphia. Thank you.
Srini, thank you very much. Thank you very much. And Sunil, thank you.
Thank you.
And Ravi, thank you very much for the opportunity.
All right.